Welcome everyone to today's webinar, How to Transform Revenue Cycle Performance with Front-End Automation. On behalf of Becker's Healthcare, welcome and thank you for joining us. Before we begin, I'm just going to walk through a few quick housekeeping instructions. If you have any questions throughout today's webinar, you can type those into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And finally, if at any time you are having trouble with the audio or video, please try refreshing your browser. You can also submit any technical questions into the Q&A box. At this time, it is my pleasure to introduce today's speakers. First, we have Paola Turchi, Revenue Cycle Solutions Lead at Notable. With more than 20 years of experience in revenue cycle management, Paola's expertise lies in identifying opportunities to enhance revenue cycle solutions, maximizing the adoption and utilization of best practices, developing and monitoring benchmarks, and leading practice management implementations and conversions. She has provided consulting services to more than 250 practices, ranging from one doctor specialty practices to large 1,200 physician IDNs. Paola is a certified professional coder through AAPC, a fellow healthcare financial professional through HFMA, and a fellow certified medical practice executive with the American College of Medical Practice Executives through MGMA. She has previously presented at HFMA, MGMA, and AAOE regional and national conferences on the topics of revenue cycle and managing self-pay collections. Paola holds a degree in business administration and a master's in healthcare administration. We are also joined today by Dane Hoffman, Revenue Cycle Solutions Lead with Notable. With over a decade of experience as a revenue cycle consultant, Dane's expertise lies in helping hospitals and health systems identify and implement process and operational improvement opportunities, improve standardization, monitor vendor relationships, and evaluate performance. With a focus on root cause identification and collaborative problem solving, he has delivered improvements across all aspects of revenue cycle operations, including financial clearance, patient access, care coverage, billing, payer follow-up, cash posting and credits, customer service, and pre-collection. At Notable, Dane focuses on the revenue cycle continuum, leveraging digital solutions and automation to improve patient outcomes, increase operational efficiency, and drive financial performance. Dane holds a degree in healthcare informatics and a Master of Business Administration. With that, Paola and Dane, thanks so much for being here today. I will turn the floor over to you.
Thank you so much, Sarah. Very excited to be here. So we have a great agenda for you today. First, we're going to be talking about critical revenue cycle challenges. Then we're going to address how organizations are solving for these challenges. And we are going to close with Dane of how we utilize intelligent automation to power growth within your organization. If at any time you have any questions, please do not feel like you have to wait until the end. There is a Q&A box on your screen, so feel free to send us questions as they come up. So first, let's start with a poll. I want to know, who do we have in the audience? Are you an independent medical group? Are you a hospital-owned medical group? What about a hospital health system? Are you a vendor? Just let us know what you represent, what type of organization you actually represent. To give you a couple of seconds while you do that, it's always very, very helpful to understand who we have in the audience. And as we go through this, and let's see, okay, let's see what we have. Okay, so we have a good size of independent medical groups, then health systems, some vendors joining us. Very good, welcome. Now let's see what best represents your role within your organization. Are we talking to providers? Are we talking to C-level executives? What about the VPs or directors? or managers and supervisors, or are you a hands-on contributor or other? There is a lot of good information. I always love to see a wide range of attendance. They will really benefit from all of the information that we have in place. Just giving the audience a few more seconds. And let's see what we have. Okay, we have no providers in the audience. A lot of VPs and directors, okay, hands-on contributors and C-level. Very good. Well, thank you so much and welcome again. We are going to start with 4 critical revenue cycle challenges that we see for 2023 and beyond. First, starting with the growing front-end denials, which leads to write-off. We then are going to be talking about the lengthy, labor-intensive processes that limit revenue capture. Move on to high-patient accounts receivable, which generates large bad debt. And finally, we're going to be talking about consistent staffing challenges, which are decreasing retention and engagement from employees. So let's start with our challenge number 1, talking about the denials, right? And this was a national denial trend analysis that included 441 million hospital claims remits that value about $500 billion in total charges across more than 1,500 U.S. hospitals. In this graph, we can see that the average denial rate is at 33% since 2016, hitting at 12% of claims denied upon initial submission in 2022. And one of the things that I found interesting, just as an FYI, is that the higher denial rates nationally we're seeing in the Pacific, averaging about 17%. In 2020 and 2021 denials were really exacerbated by COVID. I don't know if you remember all of those back and forth on how to bill for virtual visits. Should we use the virtual visit code or the regular E&M code? Should we use the place of service 11, or what about place of service 2? And the rules were just all over the place, and claims were being denied left and right. But now the new trend, as we will see later on, is in the request for medical records. It is in the second half of 2019, claims denied for medical records were at 8%. And in the first half of 2022, we were looking at almost at 14%. That is a 75% increase, which is not good. Now, similar organizations or other organizations like MDMA have conducted similar surveys. In March of 2021, they received 576 applicable responses, where 69 of these respondents stated their denials had increased in 2021 compared to 2020. And for those healthcare leaders who reported an increase in denials, the average increased denials was at 17%. But what it was really surprising to me was to see that 12% of them stated they saw an average increase of 21 to 30%. So challenges that continue to be faced by organizations when we're talking about denials. When looking at denial reasons, registration and eligibility errors really stand out at around 22%. And although these type of denials aren't new challenges for medical practices, the current labor market really has put a burden on practices with poor processes. And eligibility denials are followed by missing information, medical claims, and medical records. And this particular reason, as I was mentioning earlier on, actually moved up 2 spots from last year's results. If we categorize the denials by front end, mid-cycle, and back end, we can see that 41 of these denials are due to front end errors. And in most cases, these errors are preventable. When you dig deeper to find out what are the root of these denials, we find first that there is a lack of resources. So in the front end, there are enough resources to complete all required fields to process a claim timely. In the back end, there aren't enough resources to do what the front end resources were unable to do, in addition to what the regular tasks are. Then we have a staff attrition and training problem. So in today's competitive market, It's challenging to hire and retain qualified staff. And when you hire the staff, these resources need comprehensive education and training, and many of them are not coming from the healthcare industry. This in turn increases the denial backlog, right? They're not able to complete as many denials as an experienced person would, which affects the filing deadlines. And in turn, the absence of denial prevention strategies and only addressing the symptoms, not the causes, results in a continuous denial challenging loop. And lastly, most organizations do not have the state-of-the-art technology to help them optimize processes, which prevents them from getting out of this vicious loop of always trying to catch up, which is somewhat forcing them to work harder and not necessarily smarter. And why do I bring up all of these stats, and why are all of these challenges worth addressing? First, let's start by highlighting that 90% of denials are preventable, and that 70 to 82% of them are overturned. Unfortunately, 60% of denials are never worked due to lack of knowledge or time, and it costs a physician about $25, and if we're talking about in a hospital setting, about $100 to work these denials. So your practice could be leaving lots of dollars on the table. So let's look at an example to make it a little real. If we have an organization that has an average of 6,000 claims a month, with an average reimbursement rate of $94 per claim, knowing that it costs about $25 to appeal a claim and a success rate of 70%, if we were to have a 16% denial rate, that means that 960 claims got denied. If we multiply the 960 by 94, that means that $90,000 of revenue got denied. And if we know that we can collect 70% of them, or that our success rate is 70% of them, then we know that we recovered about $63,000. The difference there is lost revenue of $27,000. That's just from a revenue perspective. When we're talking about the cost of appealing claims, if we talk about $25 per denied claim at 960 of number of claims, we're talking about $24,000 from a cost perspective, with a total estimated net denial impact of $51,000. So that's what we'd see on scenario 1. On scenario 2, if we were to decrease the denial rate from 16% to 6%, that means that there are 360 claims being denied. That means that $33,000 would be denied, but $23,000 of that is recovered with a loss of $10,000. And then the estimated cost is at $9,000, which means that there is only $19,000 of total impact from a denial perspective, a difference of $31,000. So you can see how this is really affecting organizations financially by not proactively addressing denials. With that, let's move on to the second challenge that organizations are facing. And this has to do with lengthy, labor-intensive processes that limit revenue capture. And when I'm talking about this particular issue, I'm really referring to prior authorizations. We have had these problems for years, and authorization requirements just increase year after year after year. When I was preparing for this webinar, I was pulling data from MGMA and encountered surveys results from 2016, 2017, 2019, this year, and all of them concluded that authorization requirements had increased compared to years prior. So it's just a problem that continues to be within our industry. And according to a survey completed by the American Medical Association in December of last year, 93% of surveyed physicians report that prior authorization interferes with continuity of care. And 82% report that prior authorization can sometimes lead to treatment abandonment. So we're not only dedicating time and resources on trying to obtain prior authorization. In average, it takes around 10 to 15 minutes to complete an auth, but patient care is directly being affected by this labor-intensive and I would say bureaucratic process. And unfortunately, the solutions that we have on the table, such as 270A EDI messages, are not being adopted. According to the Council of Affordable Quality Healthcare, which is a nonprofit alliance of health plans and related associations working on streamlining the business of healthcare, only 26% of transactions in 2021 were fully automated. And fully automated transactions are those that are being conducted using 278 messages. We can see that 39% of these transactions were using web portals or interactive voice responses, and 35% of these transactions are requiring an end-to-end human interaction, such as using phone, mail, fax, or email. They estimate that if all prior authorization transactions were actually automated, the industry could save $437 million annually. So a lot of effort has been made to address this issue. We have the American Medical Association using health plan benefit managers, or encouraging health plans, benefit managers, and any other parties conducting utilization management to apply the prior authorization reform principles to utilization management programs for both medical and pharmacy benefits. We have states such as Texas. So for those in the audience that are in the state of Texas, there have been bills enacted to implement gold card programs. We even have Congress that has brought forward the Improvement Seniors Timely Access to Care Act to amend Title 18 of the Social Security Act to establish requirements with respect to the use of prior auth under Medicare Advantage plans. So there is hope in the authorization. Plus, we will share later on this presentation how organizations can address this challenge. Now, let's move on to challenge number 3 for medical practices for 2023. And that has to do with high patient accounts receivable, which generates large bad debt. In the following slides, we will discuss how patients have become a significant payer in your payer mix, and how their out-of-pocket expenses for medical care makes it challenging for them to afford care. According to the Kaiser Family Foundation 2021 Employer Health Benefits Survey, there has been a 78% increase in average annual worker contribution for a family coverage since 2008. We started at $3,354 in annual contribution on the left of the screen when you see that royal blue at the bottom. Move on to $4,129 in 2011, and then $5,277 in 2017. Now, families paying $5,969. So we're talking about a 78% increase from a premium standpoint. When we're talking about deductibles, according to the same study performed by the Kaiser Family Foundation, high deductible health plans represent roughly 30% of the total enrollment distribution for covered workers in 2021. And if we look at the average deductible amounts of 2021, and we're looking at it among all covered workers, it was $1,434 in 2021 versus $747 in 2011. We are talking about 92% increase. And when I'm saying all covered workers, we're talking about all covered workers that have and don't have a deductible. So we're assigning a 0 to those without a deductible, which are translating to the average deductible actually being higher. And another thing that I want to call out is that 29% of covered workers are in a plan with a deductible of at least $2,000, which takes me to the next slide. And in here, we're looking at the percentages of all covered workers who are in a plan with a deductible that exceeds $2,000. We can see that over the past 5 years, the percentage of covered workers with a general annual deductible of $2,000 or more for single coverage in all firms, meaning the orange line, so the line that is in the middle, has grown from 22% to 29%. And why do I bring up all these stats? Well, because healthcare for many patients is an affordability issue. According to various surveys, 40% of patients will borrow, sell something, or not be able to pay if they're faced with a $400 emergency expense. then we're talking about 56% of the patients will not be able to pay a $1,000 medical bill. 67% of them say their financial situation makes it very difficult to pay their medical bills on time. 79% say that affordability is the biggest problem in healthcare, and 93% of them believes that healthcare is way too expensive. And unfortunately, this patient reality makes it harder for medical organizations to collect from patients, especially when they do not know what to expect. According to a study performed by HFMA in October of 2020, they evaluated how the pandemic had affected priorities and consumerism strategies and confirmed that organizations were having more challenges collecting from patients, and little over 80% were finding it more difficult to collect from patients. 70% of the respondents shared that they were seeing more accounts going to collections or were writing them off. And then we had 80% or so stating that they were taking longer to collect from patients. Additionally, it costs up to 4 times more to collect from patients. And we can't ignore these balances, as we did back in the day where we were adjusting off copays left and right as professional courtesy, as these dollars now represent 30% of the practice's payer mix. And 56% of patients will consider switching providers for a better healthcare payment experience. So it's something that needs to be addressed within medical organizations. So we have talked about increasing denials, labor-intensive processes, the patient financial reality that risks 30% of the organization's revenue. Now let's talk about the last challenge before I turn it over to my colleague Dane to change, I will say, the vibe of the presentation, since I'm getting a little depressed here. But the challenge number 4 has to do with consistent staffing challenges that are decreasing retention and engagement. And yes, we're seeing it in every industry, and healthcare is not the exception. Staffing remains a big challenge for medical practices heading into 2023. Not only are we talking about staffing shortages, but also the quality of the resources available to fill the patient-facing jobs. While I was at the MGMA conference, Dr. Susan Turney from Marshfield Clinic highlighted the fact that people are joining healthcare because they are looking for a job, not necessarily because they want to work in this industry. So the soft skills that are needed to guide patients through the system are missing in a lot of areas. And according to an MGMA survey in early 2021, we can see that almost 60% of the respondents stated that their employees were leaving to get better compensation. 21 of them were leaving because they were burnout, not surprised with the pandemic, and 7% of them were retiring or leaving the workforce. Among the top other reasons, staff were leaving to temporarily care for other family members. They had a desire to remote job opportunities instead of in-person work, especially when people started to return to the office. And then a lot of them were also stating that relocation was a cost for them to leave the practice because their spouse or partner were being relocated somewhere else. So the survey also shared that one of the positions with the highest turnover was the front office, which is especially important when we are trying to support patient satisfaction. And I want to call out that while we're on this slide, that replacing existing workers costs 1/2 to 2 times the employee's annual salary. So extremely expensive for organizations to replace employees when they leave. Assuming that an average salary of $50,000 of an employee, that translates to $25,000 to $100,000 per employee when we're talking about replacing them. And the staffing challenges are further exacerbated by increasing visit volumes. A May 10 of 2022 NGMA stat poll found that 55% of practices report their 2022 visit volumes are above 2021 levels, while another 30% said their year levels are about the same as last year. So most practices are now doing more with less resources. Unfortunately, the status quo is contributing to most of these challenges. So rev cycle processes are saturated with manual flows that frustrate the patient the staff, and the providers. The patients are asked to provide the same type of information over and over again during the scheduling process, when they show up to the practice, and when they get the bill because the information they provided months ago was incorrectly uploaded into the system. Then we have, from a staff perspective, that they are being forced to multitask to levels that just increase the likelihood of making more errors. And this is then compounded by the fact that most of the information they are collecting happens to be on paper, and most of their processes are manual. And although they have a very robust and expensive EHR systems, they're not able to capture accurate information. And from a provider's perspective, all the innate inefficiencies of these systems and workflows result on not getting paid for the services that they provided. So it's a lose-lose situation for everyone. So what are organizations doing to solve these challenges? So strategies to attract and retain top talent are including high salaries, more comprehensive benefits, flexible schedules. They're offering employees the ability to work from home so they don't have to telecommute. And these solutions are proving to be effective to address staff shortages. As a matter of fact, according to an MGMA survey at the beginning of this year, 56% of respondents shared that raising wages has been the best tactic for their organization. Unfortunately, this strategy alone fosters the industry tendency of addressing current backlogs by adding manual capital versus holistically solving the other sources of the problem, which in many cases includes substandard technologies and cumbersome manual processes. So it's just adding bodies to the problem. Other leaders are buying point solutions to address the different challenges. I have seen organizations that, besides their EHR and the PM systems, they have an eligibility tool, they have an estimator tool, they have a patient portal, appointment confirmation services, etc. You get the picture. And although all of these solutions address their intended area, they tend to not be cohesively integrated with the full revenue cycle ecosystem, which then tends to have features that overlap with each other and then tend to create extra downstream work for the staff members. And others are saying, you know what, forget about this. I am going to outsource some of my processes or the entire revenue cycle to a third-party vendor. And although this tactic works for some organizations, many are truly left having to retain employees to work the complex denials and to manage patient collections. And the other reality is that many vendors that provide revenue cycle outsourcing still face an enormous amount of manual work and burden that ultimately is impacting the patient financial experience and their ability to collect because there is a lack of synchronization between these two parties. So we have seen that addressing each pillar of the revenue cycle separately doesn't really support a long-term strategy. So for organizations to fully establish a proactive patient-centric financial experience that benefits all stakeholders, they have to look at how they can better leverage their resources so they perform to the top of their license, how they can gather all the data that is needed to submit a clean claim without using the disparate systems, and how to cohesively improve processes that automate repetitive labor-intensive tasks. And this is where intelligent automation comes into play, and a solution that I'm very, very excited about is because it really supports the elimination of mundane tasks that streamlines processes by customizing the experience of those involved, and allow the staff members to improve and spend to improve, and the providers and to better improve their time or the utilization of their time, and to add value to the patient and the organization, which is solving the inefficiencies of their current technology and positions the organization to support growth versus the work today challenges of the backlog. And with that, I'm going to transfer it over to Dane so we can talk about what intelligent automation is all about and how it powers growth. So Dane, take it on.
Thanks, Paula. Paula kind of had the unfortunate task a little bit of talking about the challenges and sort of the struggles that we're going through, and I got the long straw today to go through the fun activities and how automation is used to power growth and how automation can really lead us into the future. So I'm going to walk through some of these strategies. The first thing we're going to talk about is just level set on some foundational elements that we'll talk about or that are part of automation. And the first one is optical character recognition, so top left quadrant there. And that's the ability for a computer to recognize text and turn it into machine readable format. So the example of this that we're all very familiar with, or most of us are very familiar with, would be like mobile check deposit. So we take the picture, OCR extracts the data off the check, and then that check deposit that check is deposited into our bank. The next one is natural language processing. So that's the computer's ability to read data, essentially, to read actual spoken language or written language, and then put that into machine readable format that they can understand. And an area where we use this in healthcare is actually around like care gaps. So we'll read medical documentation and determine, based on the medical documentation here, there's a care gap that actually exists. Bottom left quadrant now, we'll talk about robotic process automation, or RPA. And that is essentially bots, or machines, robots. You'll hear us talk about digital assistants, a lot of different terms. But a bot is completing user interface tasks in the same way that a human would. So the bot goes in, clicks on the user interface, types in the data, clicks the next button to move on and complete that process, just in the same way that a human would. And then the last piece is machine learning. And that's really utilizing data and the other foundational elements that we talked about here, maybe some other elements, to learn and improve processes, to learn and improve the RPA, to learn and improve the OCR, to learn and improve the NLP, to learn and improve overall processes for an organization. So those are kind of the pillars, or the four main pillars that I would say are the way we look at automation. And really tease up the next slide, we have another survey, and we start with this one for that slide for a reason. But survey question, is your organization currently using automation? And ultimately, we kind of tee up and give those definitions, because one of the things we often hear is we don't have a great understanding of what automation is. And that's something that's totally understandable, because in the healthcare environment, it's not something that we've got super involved in. We're kind of laggards, if you will, in getting involved in automation, incorporating that into our business practices. So we love to tee it up with, hey, here are four kind of foundational elements of automation, and then they lead to, do we have this? Are we doing any of these things within our organization today? So we'll give it another few seconds for some responses to come in. And I know we had a wide range of folks on the call, so that can also kind of dictate how we're using automation based on the role that we have within the organization. So I see we do have about 43% that are working with a vendor. Some internally, and then no, but considering. So I would say this is actually a pretty common spread. We have some kind of vendor, we're using some kind of automation with like a point solution. We may have developed something internally, a lot of people considering it. Like I said, we're starting to expand because of all the challenges and pressures that we heard from Paula, and we all understand and know. We're looking, where can we improve and automate our processes? So we're going to have one other poll question here. And if we are using these processes, so if we're not, that would obviously be a none in this case. But what processes are we automating? What part of the front end of the revenue cycle are we automating these processes? And the one that always stands out to me, and was actually one of the things I was very excited about, and reasons I came to Notable, was payer plan matching. And being from the revenue cycle consulting world and working on a lot of patient access projects, you've got the kind of funny anecdote of, I walk into a new organization and they've got the binder that's 4 or 5 inches thick of all the payer plans and all the cards and all the rules and ways that we match up this card and this plan to what our plan is within our EHR. And it was really exciting long ago when I was talking to Notable, and that was something that we were automating. And I was really excited. Oh my gosh, I walk into how many consulting engagements and encounter this. So that type of example is the kind of thing that you have that intrinsic, tacit knowledge that many individuals have. But if we lose that individual because they retire or they move on to a different organization, Now we don't have that knowledge. We've got to go to this massive binder, and that's something that's ripe for automation. So I was very excited to the opportunity to that case study, that example, when I was looking at Notable. So I'm going to flip over here. See payment collection, that makes sense. Lots of ability for automation there. Authorization at 42.6% as well also makes a lot of sense. There's many opportunities within authorization that we'll talk through that are ripe for automation. Registration a little bit lower, which is not totally surprising, and good to see payer plan matching, that we are utilizing automation, that process at least, maybe about a third of us are using that process in some extent. So appreciate the feedback, appreciate getting some context as where we are on the call and as organizations. I think the other thing to think about, so we have kind of the foundational blocks of this is what automation is. That's great. But how can we now utilize it within revenue cycle, within our organizations? And the key is we need to think of these three pillars, again, I'll use, in order to automate in a way that's going to drive revenue growth. And the first one is solve the core problem. And Paula outlined a lot of this. But I'll kind of take the example of outsourcing or using multiple point solutions, what we'll refer to as point solutions. And we're not actually getting to that underlying issue. Paula just alluded to this. When we're outsourcing that work, it's still manual work being done in many cases by the vendor. If we're outsourcing it, you could say, well, it's not our problem, but it's still manual work that has to be completed. We don't have an automated solution within our organization. The second piece is thinking about cohesive solutions. So if we have multiple point solutions or multiple different solutions that are kind of plugged into our organization, a lot of times that limits the impact they can have. And often it creates disjointed experiences for our staff and sometimes even our patients. So we want to be cohesive in the way we put our solutions together so that we have the best experiences for staff and for patients, obviously, but also we can have the greatest impact. And then ultimately, what are we looking to do? Iterate and make this scalable. So that means we want to create a digital workforce where we can do more work without having to hire more staff, which is obviously a lot to do with Challenge 4 that we outlined previously. So now we're going to dig into the way that we address these 4 challenges. We kind of laid all these slides out similar and then have some use case scenarios. But the first challenge is front-end denials leading to write-offs. And the way that we structured this is what I would say is current state or maybe historical state. As we said, maybe we have a little bit of automation incorporated, but we're probably not to best practice yet. So that current state or historical state is being very reliant on manual data entry. Our staff are manually entering this information into our EHR. The second sort of instance of historical state is we have very little data validation within that data. So we're manually entering data and we don't have a lot of validation in place for it. Obviously, we have those repetitive patient experiences that Paula talked about a lot. And as we've heard, these are all leading to more denials. Denials are trending up. They have continued to trend up. We kind of hoped maybe with some of the pandemic and some of the denials that were there, we kind of hoped that maybe they would start to curb, but they're still trending up in 2022. And many of them are related to the front end, as we discussed. Ultimately, it comes down to, are we working harder? Are we trying to put more bodies on this problem? Or can we work smarter? Is there a better way to do this using automation? And if we're going to use best practice, if we're going to use automation, how do we get to that automated best practice state? The first thing is automatically updating our EHR with the fields that we enter in the registration. That eliminates that manual data entry from staff. The second piece is validating data in real time. So obviously, almost everyone is familiar with real-time eligibility. That's become a standard. But what about validating other things, like your address, like your phone number? Running that validation in real time so that we know, yes, this is a valid address, this is accurate. Again, improving the accuracy of our registration in real time via automated processes. And then the last piece, pulling data forward that we have from patients. So when we have the patients engaged in a digital experience, we can pull that information that we already have on them forward so they're not having to go through the repetitive processes and the repetitive questions, et cetera, that are often commonplace within our registrations. So we round out sort of problem one with a case study, a use case example of the intelligent automation that notably uses one of our solutions, the intelligent intake solution. And really there's two things calling out here. One is the time saved per registration. So when patients are completing that digital registration, we're saving 3 to 8 minutes at weighted average of 4.2 for time for the staff time saving. So obviously that equates to staff being able to focus on more work. That equates to now I don't have to hire as many staff. I'm not just throwing bodies at the problem to complete these complex registrations. And then the last piece, a top line revenue item, also the decrease in no-shows. And what we've seen from that is patients are engaged. They get that digital intake experience a few days ahead of time. Now they're already engaged in their patient, in that visit. They've already registered for the visit. They're already engaged. It's not the day of the appointment and I can or cannot show up. You still have no-shows, obviously, but we have seen that other positive impact where patients are more engaged and therefore less likely to be a no-show. Challenge two. So challenge two, the lengthy, labor-intensive processes that are getting in the way of revenue capture. So when we look at that, we often hear about health systems kind of overcorrecting, and that's something obviously so super common in any kind of denials engagement that you're working from a consulting standpoint, where we're flagging accounts for authorization, even though the authorization might not actually be required. It's kind of the better safe than sorry approach. So then that leads to prior authorizations requiring significant manual labor. So the more authorizations we have in our work queue, the more accounts we flag for potential authorization. Now that's no more manual review that we have to go through to resolve that work queue. And then obviously, as Paul alluded to, that can even lead to clinical care delays that we begin to see. And the best practice, how do we automate these processes? One is we clean up those work queues. Use automation to clean up work queues so that we're only leaving those accounts which actually require an authorization. The second piece is actually submitting authorizations on those quick approvals or those automatic submissions, those automatic approval authorizations. And the big key there is that allows our staff to focus on the complex cases, geez, say that 3 times fast, that require clinical documentation or require that human interaction to really be able to understand the complexity of that authorization they're obtaining. And then obviously when we can lift that burden from the staff, it's going to improve our cycle times. It's going to prevent us from having these clinical care delays around authorizations. And the reason that we focus on those areas, studies that we've run, these will not be surprising probably to anyone on the call that has to deal with authorization, but actually conceptualizing and putting numbers to this was really key for us as an organization, because we find about 50% of authorization staff time is spent on these activities that we would say are ripe for automation, on the cleanup of authorizations, on those auto-approved authorizations, and on statusing authorizations. So when you say about 50% of your time on that is spent on that, that's a huge lift we can give to the staff if we can automate those processes and make this much smoother for the staff so that they can focus on those high-dollar, high-risk authorizations on very important clinical care. And then here's another case study example of that, using the intelligent authorizations tool that we have. Notable, just time saved, so 3 minutes per statusing, 5 minutes per auth submission, those quick auth submissions through portals, and then 10 minutes on an NOA submission. So just another case study of where we've been able to drive those results, and very excited about what we've been able to do in this space. And then the next example, or the next challenge, I should say, is about the high patient accounts receivable and how that ultimately manifested in bad debt. And as Paula went through extensively, patient responsibility, financial responsibility is growing. We know that's a challenge. Higher premiums, higher liabilities. Often that manifests itself in a way that patients are unclear about their financial responsibility. There's also this challenge around registration staff asking for payments, something as simple as copays. We know that's always been a bit of a challenge across the industry. Some organizations are much better at it, some struggle with it more than others. But in general, it's a challenge because you have registration staff that haven't been trained extensively on asking for money. Sometimes it's their friends, it's their family coming in. It's kind of an awkward situation. And then we've also heard across many of our partners, we actually stopped collections during COVID. And now we're in this environment where we're going to start collections again. We have staff that aren't trained on it and haven't been doing it for several years. It's a challenging environment. Obviously, all these things lead to increased costs of collections, not only due to the market conditions, but because we're having to send statements, we're having to follow up on these accounts, we're not getting that payment at time of service. So best practice, how do we automate this? One, we clearly define that patient responsibility to the patient prior to the visit. The second piece is when we're engaged with the patient digitally prior to that visit, we can also automate that collection process, which again alleviates that burden from the staff and makes us much more efficient and effective at collecting payments. And ultimately, that's going to lead to a reduced cost to collect. It's going to be able to accelerate cash and increase cash collections, but absolutely accelerate cash that maybe we may have received, but our cost to collect would have been much higher after we send out statements and follow up on that account. In a use case example here, this is again the notable intelligent intake solution and what we've seen with PreVisit revenue capture. So a range of 40 to 130% increase in payments collected prior to service, that weighted average around 76%. So very exciting to see the ability when we're engaging with that patient digitally prior to the visit, seeing that not only manifests in a better, more accurate registration, but also has a top-line revenue benefit of collecting more patients and an accelerated cash benefit of collecting those payments sooner rather than later. And then challenge 4. So challenge 4 more broader, the consistent staffing challenges across the industry and just really across the market in general, or the economy in general. So current challenges, obviously, healthcare has kind of fallen into this conundrum in general of adding staff to perform more work. We've always struggled in that competitive labor environment, sometimes even struggled outside of the competitive labor environment, but the environment we're in now absolutely puts more stress on staff, puts more stress on our ability to compete and hire good staff. And then as Paul alluded to, even when we're able to hire staff, sometimes it's just because people are looking for a job and less that they're looking to be engaged in healthcare. So sometimes those soft skills aren't there. And that puts us at another disadvantage of course, hiring the right staff or the most qualified staff. And then ultimately what that leads to, it puts this healthcare in a box where we kind of have to patch together point solutions. So how do we automate this? And what does best practice looks like? One is utilizing intelligent automation to perform additional work without additional headcount. That is the key. Number one, stop. We have to do additional work without adding headcount. That's going to curb our exposure to the labor market, and any future labor market changes, whether positive or negative, we're going to be in a better position to deal with those challenges that exist within the labor market when we can do additional work without that additional headcount. And then obviously one of the ones we've talked about throughout our conversation today is consolidating automation on a unified platform. So that's going to make things easier for our patients, it's going to make things easier for our staff, and ultimately it's going to give us a better environment for our staff to work in, which is going to result in less stress, less turnover, and better retention. So rounded out with just an overview, these are the solutions that Notable has in place right now. And you'll notice, obviously, we talked about intake and authorizations as two case study examples today. Scheduling, population health, and referrals. You'll notice these are all very patient access related. And that's by design because everything we've talked about today. We know that so much of the revenue cycle and so much of the challenges that we face can be alleviated if we get things right further upstream in the revenue cycle. Anyone that works in patient access or revenue cycle has heard that till they're blue in the face. And ultimately, as we continue to look to expand our solution set, we're always looking to where can we drive the most value and have the greatest impact on the revenue cycle, on patient access, on our with our partners and with our patients. So appreciate the time today. Hope that was very informative and helpful. I know we've got time for questions, maybe 9-10 minutes left here. So I think we'll open it up, but I'll turn it back over if there's anything else, kind of official that we need to cover. And if not, I think we have questions.
Awesome. Thank you so much, Paula and Dane, for sharing how healthcare organizations can transform financial performance with the use of intelligent automation to increase copay collections, minimize denials, and reduce cost to collect while freeing up staff capacity. And thank you to the audience for the thoughtful questions. Please continue to submit your questions through the Q&A box, and if we're not able to answer your question on the line today, we will follow up with you after the webinar. So we'll get started with our first question for today. What areas of the revenue cycle do you see commonly being automated?
I can take this one, Dane. So can you guys hear me okay?
Yes, we hear you. Thank you.
Oh, okay, good. I'm just checking. The revenue cycle as a whole, is ripe for automation from beginning to end. But what I will say, however, is that most organizations are starting to automate their front-end processes, as these are, for the most part, causing 80%, if not more, of their challenges. This also is giving you the opportunity to not only improve internal outcomes, but also engage and retain patients in a more meaningful way. So I would say from an automation standpoint that delivers most value to the organization front end to begin with.
Great, awesome. Thank you, Paula. Next question is, what is the biggest objection that you see for automating front-end processes?
Paula, you going to take that one, or should I?
Go for it. Go for it.
Go. I think there's a couple. I think in general, there's in healthcare we have this sort of desire to control everything. And I think that's hard. Sometimes it's hard for staff, it's hard for leaders, it's hard for people within the organization to understand that aren't familiar with automation, how we still have full control over the inputs, we still have full control over the validation. In fact, we have better control over the inputs. We have better control over the validation. We have better control over the results when we're able to implement intelligent automation in a way that's easy for our patients to use, which is easy for our staff to use, which limits the burden on our staff. And I think in general, that might be the biggest challenge or thing that we see. And it's something that I think we're getting much better as an industry, kind of getting over that challenge, or that frustration or that lack of understanding. Oh my gosh, well, we don't have full control over this. Well, actually, having a registrar have full control over this, in many cases, in fact, in all cases, results in lower lower accuracy. So I think that's something that we're getting used to as an industry, but still sometimes we run into that challenge some. And it just really comes to an understanding of how do we use automation, what are the guide rails around that, how do we get the best results and the highest data accuracy out of that automation.
Awesome. Thank you, Dane. Next question is, do you recommend having a variety of automation tools to support the different areas of the revenue cycle?
I'll take this on. So not really. I would recommend that organizations look for a partner that is able to support all automation needs. The biggest challenge that we see in this industry is really the wide variety of point solutions that have been implemented to address the gaps in the revenue cycle. And like I mentioned in the presentation, some of these solutions overlap and they don't fully integrate with their EHRs and PMs, which kind of like defeats the purpose of streamlining processes. We see a lot of instances in which solutions are implemented to automate processes, but instead of automating the process itself, they are creating more work in the back end for the end users to address. So maybe they are automating the front end with the patient registering themselves through their mobile phone, but then they are not really integrating all of the data elements into the EHR, and the end users are having to manually do this. So because of that, I would not advise to have multiple automation solutions. I would encourage organizations to have a platform that supports all of their needs in a holistic way.
Thank you, Paula. The next question is, our team is starting to see the limitations of an EHR-first approach. What's been the biggest reason that organizations decide to use automation in spite of the pretty significant EHR investments that they've already made?
I'll take this one. I think that ultimately, there's a couple things. Ultimately, EHRs were meant to be the system of clinical record and the system of record. And therefore, they've been built with that goal in mind. They haven't been built around patient engagement. They haven't been built around, essentially increasing revenue cycle performance or ensuring that we're getting paid. So I think that is sort of the first piece of it, is those EHR solutions just weren't built that way. So I think that that's kind of number one. And then in the number two, there's so much like tendency to try to build a point solution that doesn't drive to the results. And that's what I kind of tie to the three pillars that we talked about in what we're driving to do around exploring, solving the core problem, implementing comprehensive solutions, and then iterating and scaling. Often those EHR solutions that we've seen don't necessarily get the results that we want because they haven't been built to get the results that we want. So if we have a low patient engagement with an EHR solution, it's not going to get the results that we need. So it's better to go for a vendor or an outsourced solution around automation that's going to get the results, because then we're going to ultimately, we're going to get the engagement, which is going to ultimately lead to the results.
Great. Thanks, Dane. How have you seen physicians and staff react to automation?
This is probably the last question and one that I really like. I tell you, change isn't always easy, and although there is hesitation at first about automating processes, trusting the machine to do the job behind the scenes, once it is understood, and it really generates a sense of relief and is widely welcome. I know there was another question in the audience about how to alleviate the staff concerns or resistance to automating processes historically done manually. And to me, the best thing that I can tell is make the team members part of the process, right? Help them understand how the processes are being implemented. What is it that the machine is doing? At what point does the machine end the job, and at what point does their job start? One of the things that we see a lot is overlapping. They redo what the machine has done. So that's what I will say. And the reality is that no one is thrilled about doing data entry and asking the same question over and over again. Not the physicians, not the staff, and trust me, neither do the patients. So make them part of the process, and you will see how once the buzz of automation has entered the organization, it quickly spreads into other areas.
Great. Thank you so much, Paula and Dane. And thank you to our audience for joining our discussion today on how to transform revenue cycle performance with front-end automation. We hope you all have a wonderful day.
Thank you, everybody.